start. So this is not a basically a technology lecture. It is how this AI which can help us in day-to-day our practice. So our tagline is redefining healthcare through innovative technology and dedicated human touch. Now, whatever we are discussing about AI, the biggest negative point about AI is dedicated human touch. So bankers heart, we always redefine healthcare by whatever new technology is coming, we try to understand that, try to use that, and we try to have maximum individualized, dedicated human touch on the field. So before going into that, the mainframe computer started in 1940s, which is then upgraded with the software revolution, and the personalized computer like Pentium started in 1980s. Internet and cloud started in 2000, and AI and machine learning started in 2015 onwards. And now we are going into different phase, that is a generative AI. And this is 2022 onwards. And the sky is the limit. Okay, we are going to see another 5 to 10 years a different type of practice. So I am just giving you a glimpses of what is happening across the world, and especially in my field. So before going that, let us put this question hypothetically. Just 1.5 months, I think just 15 days back, similar patient I operated. 60-year-old, ejection fraction 25, coronary artery disease, triple vessel disease, diabetes, hypertension, 10 years, chronic smoker. What will you do? How many of you still send this patient for either bypass or PPC? So the thing is that normally how we decide?
Viability.
We have a data, either journals gives a data, and after analysis of that, like odd ratio, statistical data, and that is how we decide whether this patient should go for a CABG or this patient should go for PCI. But in this same patient, normally without any computer or without how we decide, like normal scenario. This is a high-risk patient, 60-year, triple vessel disease, most probably diffuse disease, possible CTO, ejection fraction is 25, there is comorbidities like type 2 diabetes, hypertension, smoker. Likely issue will be poor distal target, high perioperative risk, high long-term event risk. And this is a classic heart team decision case. So normally, when we discuss in a platform like this in a heart team, so there are only two main frames, CABG with PCI. So when I have to see for a CABG what are the benefits, so survival benefits are definitely there in airway dysfunction, diabetes and multi-vessel disease. PCI should be considered when surgically it is very poor target, not able to graft any vessels, or patient is too frail or very high operative risk because of the other comorbidities, or patient refuses, or there is a acute MI like situation and he requires rapid revascularization to save that patient. In that case, we consider PCI. Now, how AI predict the same patient? So if I put all the data in the AI, generative AI, so it gives prediction like this. So if you see the predicted CABG, the outcome, the operative mortality is 8 to 15%. Majority morbidity like stroke, renal failure and sepsis 25 to 40%. Prolonged ventilation 30 to 50% patient. Low cardiac syndrome after surgery 40 to 60% of the patient will develop this. And ACAR requiring dialysis require 10 to 20%. But these are the AI insight generated by AI. Strong predictor is ejection fraction 25 is a dominant driver because they use data. Diabetic, bone infection and very prone to the infection. Creatinine is elevated, renal failure risk is there. So AI model consistently shows CABG still offer a survival benefit despite high early risk. Long-term survival after 5 years is say 60 to 70%. It's better than the PCI because now I am coming the same patient for PCI. Same patient I put it in the generative AI to make me understand should I go for PCI. So the immediate hospital mortality reduced from 10 to 14% to 3 to 7%. Contrast induced AKI very high, 10 to 25%. Incomplete revascularization, 40 to 70%. Because only the culprit patient they will do plastic. Repeat revascularization in 1 to 3 years, 30 to 50%. And a heart failure progression is very high. So AI Insight says short-term safer than CABG, but residual ischemia, poor LV recovery, high long-term mortality in diabetic plus CVD, 5-year survival is inferior compared to CABG. Now, if you compare this parameters, both CABG and PCI, the early mortality, which is higher in surgical side, whereas in PCI it is lower. But the rest, complete revascularization, LV recovery, repeat procedure, long-term survival is far better in the CABG. Now, how we use this same patient, if I need to operate, I put on a different way. What I can do better to reduce the operative mortality? Whether I should delay, sterilize, optimize, hydrate, improve the little creatinine, or improve with the SGLT2 inhibitors and Yamada and all this thing. And then I will put the same patient after 2 to 3 weeks or 4 weeks. I will just take little bit delay time. Same thing happens with Mayur Jadav's, our intensivist uncle. 15 days back, he came 6 weeks prior. We postponed, creatinine came down, everything improved. He had a very stable recovery. 1 day in ICU, 2 days in ward, 5th or 6th day patient discharged. Same patient. So same thing if I put it in a Euro score. Normally STS score is there and then a Euro score is there. So any patient pre-operatively we wanted to evaluate. Before the AI, there was a Euro score and something like the STS score. So what we used to do is we put the data in a Euro score format and then we predict. So it gives, Euro score gives inferior prediction compared to the AI prediction. I have compared the same thing, I put the data of same patient in these two different things. They give a prediction operative mortality 6 to 8%, here 10 to 15%. So it is more radical, more aggressive AI. So now the question is, would you trust AI for this patient? Anybody?
I say कि हाँ criteria for all age groups है कि the defined age.
60
हमारा
years.
AI ना data.
60 years. One single
Because
patient.
in India we get younger patient.
Yeah, we get different. Our demography is totally different. So if AI predict better than us, are we ready to accept it? The second question is this. The real problem is not the what Euro score is there, whether the AI generative prediction is there. The real problem is the same patient, different decisions. Some physician go for a PCI, some physician go for CBG, some medically manage such patient. The guideline says different, real world complexity is different, AI complexity is different. Risk score doesn't capture everything like you said. Our demographic data is totally different and it is not there online because we don't put our data online. Because Western data are all systematically, it is stored in one compartment and they analyze. So whatever data, generative AI data analysis they are doing, that is all Western data. Indian data we are not using at all. So outcome remain unpredictable whether you go for CABG, PCI So ultimately the truth is, this is where the real challenge lies, not in knowledge. We know everything, sir. If you put little bit time, 15 to 20 minutes behind that patient, we come to that level only whether to send this patient for PCI or will send this patient for CABG. But decision is uncertain. So this is the real issue. AI is not the future, it is already here. The question is, are we ready? That is a big question in 2026 April. Today, healthcare is facing 5 major challenges. It is data overloaded, increasing patient load, delayed diagnosis, need for personalization and ICU complexity is higher and higher. AI is not here to replace us, it is helping us to convert complexity into clarity. Especially in cardiac care, AI allows us to predict complications like AF, sepsis, outcome, a stroke, low cardiac output. This is why AI is no longer an option, it is becoming an essential tool and we must learn AI. Why AI is needed in healthcare? There is an explosion of medical data from electronic medical record, imaging data, lab data. Human brain cannot process all. Even normal time, AI was not there. We do 100 patient analysis, put the data on the computer, Excel sheet, database, and then analyze the data. This is same thing AI is doing now. Need for early diagnosis and accurate diagnosis. Diagnosis delayed, worse outcome. If you put the X-ray or CT scan, you can miss one small tumor, but AI will not miss. So it gives exact, accurate, not exact, but at least 98 to 99% detection, especially for mammography, X-ray, CT scan, MRI. ICU and critical care. What we require is continuous monitoring, and many variables are there. Like in our ICU, if you go, the continuous ECG 6 leads with ST segment alarm, as well as ETCO2, CVP, arterial line, SpO2, everything. Now, it is humanly not possible to monitor each and every single seconds, but AI can, and it can give me bip on my wearable AI tool. Increasingly patient loads are increasing, like already in Bankers Heart, we are more than 50,000 patients. So more patients, limited doctors, time pressure effect decision making in your own practice. If you have 100 OPD in the same day, and if you have a 20 patient in the same day, what will happen? When you have a more patient, you need to finish fast. So time pressure effect decision quality decreases, AI improves efficiency without increasing the work overload. There is a demand for personalized treatment, like one treatment for all is outdated now. Patient need individualized care, AI-enabled precision medicine is in line, better outcome and patient safety is required, reduce error and omission, evidence-based decision support and improve survival and quality of care. So healthcare is becoming too complex for human-only decision making. AI makes it safer, faster and smarter. For example, most of you are used the BPL ECG machine. Now the new machines are came with they give report or almost 90% time, 95% time it is accurate. It will predict everything, whether it is anterior wall, inferior wall, lateral wall, or whether rhythm is what, rate is how much. We don't need to calculate now. In old ECG machine, we can now understand also. It's very difficult. So coming to introducing this topic, AI in cardiac surgery. AI has revolutionized heart care and artificial intelligence, enhanced diagnosis and imaging, improving surgical precision and predictive analysis and patient outcome. These are the reality in most of the Western high-end institutes. In India, in few centers, they have already started. We have also started little bit. We have just started. So coming to final thing, what is artificial intelligence? We need to understand. So AI is basically ability of machine or software to perform tasks that normally require human intelligence. So how it does? By 3 data protocols, like machine learning, it predicts outcome, deep learning, analyze image, NLP, that is natural language processing unit, that is extract electronic medical record inside. So what they do is, it analyzes the data, find the pattern, the deep one, understand the deep pattern, and then it gives prediction and it gives decision. So this one thing can be done by one AI. So don't think of AI as a technology. This is a smart assistant that learns from data. So you can understand that the machine learning, it learns from the data and pattern. It is algorithm. It is a statistical model. Then whenever it is required, the deep learning, the all pattern, it will analyze like complex pattern. And then what we discuss with AI is NLP. We are not discussing anything to any AI in a form of machine or deep. Whenever we are giving a prompt, that is through NLP. And whatever report comes or reply comes, it comes by natural language processing. So it can give us in any language, any text, and whatever way we want, they give. Now what is for this? Because it is a communication link between us and the AI. This NLP, we need to understand what is language processing. It is a field of AI that enables computer to understand, interpret and generate human language in any language. Whatever 256 languages are there, any language it can. Simply for us as a doctor, NLP is how machine learn to read, understand, respond to human language just like we do in a regular way. So it allows us to understand the text like report, notes, prescription, understand the speech like voice command, dictation. It generates a meaningful response like ChatGPT. Translate language, suppose my patient is from Arab, Iraq, and he doesn't understand anything, so I can explain to him with using AI. And if we have a huge big letter and I wanted to summarize, I don't have that time to read full email, I just put that in the AI, it will give me just the glimpses what is to be understand, summarize that whole email. The core concept is whatever prompt you give, it divides into multiple small words. That is called tokenization. It understands the grammar, and after that, it understands the meaning. Now, what is that? It understands the context, why you have asked that. Like for example, you write, is it cold? He is confused. He will ask you whether you are asking about your health or temperature. Okay. But if you write the full sentence, okay, I am in Gujarat, I am in Vadodara, today is April, he will understand. Then he will say, today's temperature is this. But if you say that I am having a cold and I am having a running nose, he will understand that because he will understand the context. At the same time, whatever prompt you give, whether it is a positive or negative, that also, the sentiment also it understands, generative AI. And after that, they write language generation like report, summarize and reply. Whatever ChatGPT reply comes, that reply comes after that. So how, as a cardiac surgeon in our field, it helps. So NLP can be helped in clinical documentation like converting. If I have a voiceover in my OPD, whatever I am speaking to the patient, it will be automatically charted. The structured OPD notes it will generate. Auto-generated discharge summary, I just need to pick up a phone, record it, orally, or when I am operating, I just have to speak some word. It will be up at the end of, by the end of the surgery, the OT note is ready, discharge summary is ready. Data analysis extract insight from the patient record, identify trend in the ICU complication, decision support like summarize the latest guidelines. Suppose if I have an issue or difficult patient, I put the data. What is the latest guideline regarding this patient? I can understand that. Suggest a differential diagnosis from the symptoms. And it is simply complex report for the patient. It simplifies that. Not only that, it generates patient education content also. So these are the things where NLP used very systematically. In our life, we normally use this NLP in a Google Assist, understanding the voice command. Siri, in an iPhone we use Siri, that answer the spoken question. These are all NLP. ChatGPT, Google Translate. So one line summary is that it is a communication breach between the human and machine, not the other two parameters. The last one, NLP, is very important for us. Now we need to understand what are the types of artificial intelligence. So what we use at present is a narrow AI. It's a very weak AI. The thing is like I gave you an example of ECG. So it does only the specific job, what is given to that task. Like ECG, AI-enabled ECG recorder will give you only ECG part. He will not give treatment, he will not suggest now you go for echo, TMT or angiography. It will give you that only. So design for specific task, cannot think beyond the program. Example, ECG interpretation, like radiological image, all images can be easily analyzed and given the report. ICU prediction tools are available, and we are within 5 to 7 years, it will be total AI generated ICU care. So this is the way AI, weak AI, narrow AI we can use. Now what is their second part, the second type, that is the general AI, which is the strong, which is future. Can think, learn and reason like human. It performs multiple tasks across domain, still under development, equivalent to fully trained doctor. It is there, practicals already started in China, Japan and Korea, but not in the reality. It is in a research phase. Now the third one is very dangerous, super AI, theoretical. Intelligence beyond human capacity, can outperform human in all fields. Currently hypothetical, not yet real, there are ethical concerns. Today we use narrow AI, we are building general AI, and we are debating over the super AI. So if you see the narrow AI currently reality, generative AI is future, and the super AI, either it will break through or it is dangerous for all of us. So how we use in a cardiac surgery, the main topic, the pre-operative AI tool. The planning and decision making, that is the most important thing. Any patient comes especially complex, patient selection is very important for us. Risk prediction, surgical planning like plan A, plan B and plan C, all should be there when I am going into theatre. Anatomy visualization, AI can give me analysis of X-ray, CT scan, even angiography, patient data, and suggest optimal strategy and outcome. These are the things already available in the market and anybody can use it. This is subscription based tools. The heart flow, which converts CT angiography into functional ischemia FFR CT, helps to decide between CABG, PCI or just a medical management. Clinical impact gives is avoid unnecessary angiography and angioplasty. Ultramix is AI-based echocardiography analysis. It detects CAD, LV dysfunction, valvular heart disease. You can use it for OPD or pre-operative certification. Circle cardiovascular imaging, cardiac MRI, automated quantification, LV and RV volumes, fibrosis, amyloidosis, and restrictive cardiomyopathy, dilated ischemic cardiomyopathy, idiopathic cardiomyopathy. Best for complex LV dysfunction and viability assessment in ischemic cases. Brain Lab, AI-based 3D reconstruction plus surgical planning, navigation-ready models. We can use for complex aortic or redo cases. It will give me a picture where I am going to face the problem. So when I am doing a redo or when I am doing a regular complex case, it will give me idea that this is the place and this particular minutes and this particular second I am going to have a problem. So that time it will alert me. So AI improves segmental accuracy, reduce planning time. At the same time, this model, AI risk prediction model like STS and ML model, it is by STS database. AI-based mortality predicted to custom ML dashboard. It can predict the mortality, ICU stay and complication, AI-enabled personalized risk classifications. Intraoperatively also we can use these tools. What they do is real-time guidance, image navigation, because if I am operating the same time image is coming in front of me, whether I should be doing that OM or not, it will predict me, it will give me, and then only I will do that. Robot, somebody asked me robotic assistant, it is also one type of generative AI. AI can guide certain like GPS navigation during the surgery. These are the platforms already there in the market, like Da Vinci surgical system, robotic assisted cardiac surgery, minimal invasive CABG and valve, advantages, precision and tremor elimination. AI image guided navigation system, neurosurgeons use very regularly. Like example is SGSTK and brain lab navigation. It is there in big time. It is there. Real time anatomy mapping like pituitary tumor which can be assessed very nicely. Brain skull based tumors. Many things with this AI guided navigation system they are doing. Graft placement guidance, especially in a cardiac surgery. So AI with the augmented reality improves the intraoperative accuracy and safety. Similar way, augmented reality surgery, it is also there. It helps in overlay coronary anatomy during surgery. It gives me exactly overlay. So whether to do this, that or not, visualize the hidden structure which is not visible to me. That also, suppose if I put an echocardiography video and if I am doing a mitral valve, so mitral side if I am seeing the mitral valve, but ventricular side I am not. But if I put into this AI, it will give me ventricular side also, 3D reconstruction. So that's an amazing thing. Emerging AI assistant is the future, cardiac GPT, it is coming up in a big way. It will give, it is not yet there in the practice, real-time suggestion and workflow optimization. Post-operatively also it will predict, monitor and optimize. These are the tools which is available, predictive ICU AI platform, remote monitoring AI, imaging follow-up AI, AI automate ejection fraction, strain, valve assessment post-operatively. These are, I have taken a screenshot of these all AI tools website, front page. So you can understand that Ultronomics, EcoGo, heart failure, it will give us AI guided and HF, EF measurement. This heart flow, it give me a manage the CAD for a life. Similarly, brain lab, especially it goes for spinal surgery and neurosurgery. And AI-driven remote patient monitoring device. My all patient, I have everything on my wearable. This one. It will give me if the patient is fibrillating, patient is having atrial fibrillation, patient is going into low. I don't need to call my physician in ICU. It will give. And days are not far, even from my wearable, I can change the ventilating setting, I can change the infusion pump setting also, whether to increase something or not. Not only that, our life is not only about surgery or consulting. We have other things also like administration and documentation. Like they save a lot of time, this AI, reduce my burnout. Okay. Like Suli AI, it can give you help for a OPD documentation, scribe, discharge summary, twofold help automate our clinical notes, progress tracking, or workflow AI, it can case control, OR intelligence, OT scheduling and resource optimization is very important for, it can help. Similarly, research, because we are dealing with the medical practice, we are into research and education also. So paper writing, data analysis and teaching is also part of our life. So ChatGPT give me literature review, PPT presentation, like this presentation is helped by a lot of AI generated images as well as AI generated slides. Patient education, MonNI is built for your own AI model, research and imaging. Similarly, simulation and VR platforms are coming in a big way. It pre-operatively only practice on a visual reality platform. So AI can help in research and education also. These are the advanced. It is going to come in a few years now. Like digital twin patient. Same patient you will have as a digital. Then you have to perform surgery like virtual heart simulation before surgery and real-time alert during grafting and automated ICU like AI-driven ventilator and drug titration. So these are going to come in another 2 to 5 years, 10 years down the line. Finally, simplified framework for pre-operatively diagnosis and planning, we can use AI. Intraoperatively navigation and precision, we can use AI. Post-operatively prediction and monitoring, we can use. And for practice, documentation and workflow to reduce burnout. And academic research and teaching, we can use this. So, as I said in the patient, the AI prediction is much specific and capture complex interaction. So, traditional score gives inferior prediction. AI in cardiac surgery, like you can have a LV assessment, a mitral valve assessment, PA pressure assessment, like thickness, everything. At the same time, CT angiography, it can give us a calcium score prediction, length, breadth, how much calcium is there, what to do, FF functional flow reserve. Similarly, cardiac MRI viability, it can predict viability by documenting this through AI, and which can give you almost 98% accuracy. It gives me, this is the wrong labeling, but AI in surgical decision making, like whether to put this patient for CABG, and then if I am doing a CABG, it can assist me which target to target in a surgery and what conduit I should be using so that it will last long. So it helped me in the operative field also. And after doing surgery, during the surgery only I need to speak, and it will generate this type of operative note, like operated XXX, 62-year male, TBD, severely dysfunction, CABG, severely Lima to LAD, whatever I speak, they will write. It can predict, as I said, fibrillation, ventricular fibrillation, ectopic beat, complete heart block, sepsis, ventilatory duration, not only that, low cardiac output, and many things, respiratory distress. So key studies behind this one, the STS adult cardiac surgery database, which includes a mortality prediction, is proven. Mimic 3 database, ICU complication prediction, it is already there. JACC and Lancet Digital Health, AI outperform traditional model. These are the key studies. If anybody wants, I can give a link. But there are limitations of AI. Very important. because the AI gives you a black box issue. Now what is black box? AI reaches a decision but cannot explain the reasoning clearly. It gives you a decision but it will not give you clarity clearly. So AI in cardiac surgery is powerful but has critical limitation, like human oversight and expert judgment is necessary. The data continuity problem, the error in data, as I said, our data are Indian data. It is not there in the market. But these are the data which are Western data. ECG noise can give you wrong data. Imaging artifact can give you wrong data to accurate prediction. Another thing is low generality. AI model may not work well on a different patient population. Limited adaptability, like today's AI can't handle unexpected event in real-time surgery. Like suddenly patient collapse, suddenly there is a anterior wall ST elevation, which cannot be predicted, which as a human we need to see. It can give you alarm, beep, everything, but it cannot predict. Interpretability and trust. Surgeons need to understand and trust AI choice before using them. There are lots of AI which to trust. If you ask same question to ChatGPT, Gemini and Copilot, all three will give you different image and all three give you different answer. So which one to, so by using repeatedly, you will come to a conclusion that this AI is good for me. Similarly, ethical and legal barriers. Suppose AI gives you wrong interpretation and patient dies. Or patient something happens. Who is responsible? So these are the ethical issues. So misjudgment, liability, consent, patient consent issue. Lack human judgment. AI lacks human intuition. Like intuition, empathy. कहाँ से आएगी? नहीं आएगी. So experience, our experience, whatever in ground we are doing so many years. Complex and nuanced decisions, we need to have these are the issues, but over a period of time, another 5 to 10 years, if strong AI, new AI comes, in that case, it will be a reality show. AI in cardiac surgery is powerful, but has critical limitation. Human oversight and expert judgment is essential. Take-home message is AI is tool, not a replacement. Clinical judgment plus AI insight is that what we should be doing. Early adopter will lead the future. AI plus our own judgment as a surgeon, I will be better surgeon. Final thought, AI will not replace cardiac surgeon, but surgeons who use AI will replace those who don't. The top 10 AI tools which every physician should know. For documentation and burnout reduction, ChatGPT, Nuance DX, that is Copilot, Suki AI for voice detection. Clinical intelligence and decision, Glass Health, up-to-date and Embos Lisa. And for advanced clinical AI, AI Doc for AI imaging, Viz AI for stroke alerts, HeartFlow for FFR CT analysis, and innovation, that is for predictive care. So AI will not replace doctor, but doctors use AI replace those who don't. So thank you very much, sir. This is to my personal thing and not for this lecture. Any questions?
There was news in local press that hospital will replace the radiologist by AI.
It is debatable topic, sir, but I think it will not be.
Already done last week in one of the university hospital in US. The CEO on record went to told on public platform that we are replacing radiologists with AI.
So what has happened in USA, one of my friends, Baroda based, Mr. Jailesh Patel, his sister's husband, he is a radiologist. So 20 years back, what he has started, the online data, you will see at one place he is attached with 50 hospitals. No radiologist there. all X-rays, all CT, all MRI, he will report from one place, sitting in his underground chamber. So it was already like that, and that is the reason that nobody is now taking radiology.
Another, see, you said pre-operative evaluation. The patient with comorbid condition, we will presumably put the data inside. Do the AI will suggest, do this investigation, do this investigation, before giving medicine.
It will give me, and this particular patient, I give the same data. He said to wait for 3 weeks. You give Eucomix, you hydrate the patient, you input, output this one, you start Vaghela, do this, you do that, okay. Call after 1 week, every week you do echo, PA pressure should reduce, 65 PA pressure came down to 45 and then 35 when I operated. Patients smoothly stay. It is not a one case. I am using only whenever I have a difficult case.
We already have cirrhotic patient.
Cirrhotic patient. Same patient, I use the AI data. Okay. It has given me prediction. This can go wrong this way, this can go this way, right pleural effusion will be a problem. You might have to tap 2 or 3 times, or you might have to do sclerotherapy. Everything it has given. I can give you that. I have kept it in my record. For DMB student, it is a short note for 4th paper. AI in Kayak. So you can take this and few things you can write from this.
One more comment is that this AI which we are using should not be used on a just casual way.
Yeah, you cannot.
So you have to have a proper program as you are showing all this to use that particular thing.
Yeah,
Most of
we
the
have
people
to
will
do
just
our
do a
work.
Google, ChatGPT, and then we will not get the right answer.
We have to see the patient,
Yes.
we have to understand the ground reality.
And the place where you use also, because
Yeah.
that is the very important. Second thing is the boosting of the AI, like you have to put it, the AI, the more the data you feed, the more the answer you get.
Absolutely.
So that data has been fed nicely in these specific programs. So for example, if you are doing clinical intelligence, then you should use glass health or any of these 3. You can't use the other one for this.
That is the reason that the
Yeah.
narrow AI is good for us.
Yes.
Narrow AI is very good for us, like ECG. The
Right.
latest ECG machines are narrow AI. Like generative wearable AI. Okay, my ECG, all patients I can see, one particular patient I can see.
Yes.
Everything I can do, and it can give me alarm. That's all. I want just alarm, whether it is the heart rate is falling, BP is falling, saturation is falling. Even my ICU physician is not around or staff is not around, I can just give a call to them. So it will be reality that all the doctors in the team working in the one particular time, on all nurses, they will have a wearable this type of belt or watch or something like that, and it can give us a better. So basically, it is a personalized treatment to the patient. Everything we are doing, but these, of course, it has got a cost because every AI, huge amount of monthly charges. Like I have used only 2 tools so far, brain lab and one is that CT angiography wala. It's $65 for one image, one assessment. But still I wanted to understand that, so I use that. But in day-to-day practice, if I have to ask the DB sir to give me 20 to 30 lakh rupees monthly, it's not possible. Thank you.